I am Mahmoud Hafez, Professor of Orthopedics at October 6th University, Cairo, Egypt. I am going to talk about evidence-based medicine. This is three parts, and part one is going to focus on quality of papers with example of randomized controlled trials. Part two is going to focus on level of evidence with ranking of journals and plagiarism. And part three is a practical example of evidence-based medicine applied on management of fractured knuckle femur. Objectives of this lecture is first we're going to discuss the basis of medical practice and then look at evidence-based medicine's definition, components, and steps, and look at quality of papers and literature search with ranking of journals, identifying poor quality journals, which are called predatory, and define what is plagiarism. And then we give a practical example about the management of fractured neck of femur, having 17 questions answered using EBM. We are in Egypt here practicing medicine, but everyone should ask a question. How should I practice medicine? Based on what? Is it based on my hospital training that I had like several years ago? Or is it based on the knowledge and recent textbooks that I'm reading? Or is it on references or preferences of patients? Or is it only based on personal experience over the years of practice? That could be several years, 30, 50 years or more, and advice from colleagues? Or is it based on reading recent articles in the literature, including case reports and retrospective studies? Basically, it could be all of these. Plus, most importantly, is a high level of evidence studies, like randomized controlled trials, systematic review, or meta-analysis. And this is a classic definition of evidence-based medicine. It is the integration of best research evidence with clinical expertise. This is a slide from the internet showing the major components of evidence-based medicine, which is patient, physician, and information. And then there should be a question or a problem that these components are going to work on. Also, it has been defined as there are 5 steps of EPM. First, you have a clinical question, which should be patient-focused, problem-oriented, as we're going to give an example of it in part 3 with a fractured neck of femur. Then you look at the evidence through your literature search, and we will identify what is the best engine for literature search. Then you find that evidence, and then you have to critically appraise, to evaluate this evidence for the quality. So you find a paper. This does not mean that you're going to take this paper and apply it. You have to critically evaluate this paper to find if it's a good one really to follow or not. Then you're going to follow the recommendations from that paper and apply the evidence and implement this in your practice. And then you have to evaluate at the end the information and the intervention you did and the whole process of the EPM. This quote from British Medical Journal, and it's very important for every practicing physician, surgeon in this era, that you should need to learn how to review and critique articles. If you look at that, what's written there, the 21st century clinician who cannot critically read a study is as unprepared as one who cannot take a blood pressure or examine the cardiovascular system. The classic format of any scientific paper will be formed from an introduction or a background about the subject, then the methods or patient methods, then the results, and after that discussion with the conclusion, and then the references. And this will include also drawings and tables. Here is the literature search. The best one for physicians is basically to look at midline. And here is a link for midline with the PubMed. And I'm just giving an example here of a paper for myself. So when you log, you can look at authors, you can look at journals, you can look at subject, and you have to be careful when you put your keywords because if the keywords are not accurate, then you're not going to get the search that you're looking for. If you find a paper, how do you know if this paper is good or not? That is through something called level of evidence. So the level of evidence, we have 5 levels here. The lowest level is number 5, which is expert opinion. So when you ask an expert, a worldwide expert in a subject, this is level 5 of evidence, which is the lowest of the quality. So we're starting from the lowest and then we're going up. After that, number 4 is case series or case reports, where somebody is publishing one case or few cases. So here there is no statistics, and this could happen by chance. So it is not as accurate as higher levels. The higher level of this is a retrospective study, where you have a study of large number of patients, but it is retrospective. So it is not through the hospital notes or files getting the data and information, and some data could be missing, and there is no real design of a study at the time when the medical notes were written. Therefore, the quality is not as high as the level 2, which is a prospective cohort study, where you design a study and then you have really good control on the data collection and on the statistics, so that you can have a better quality and a higher level of evidence. The best evidence is level 1, which is a randomized controlled trial and systematic review of randomized controlled trial. Here is why randomized controlled trial and why it is a high level of evidence, because there is no bias. Because if you have a level 2 where is a prospective study, and for example a surgeon or physician selected the best patient that can give best results, then this is bias. تحيز يعني. So in this case, if you want to avoid bias, then you have to make a randomized controlled trials. And randomized controlled trials means that the researcher has no control on the selection, because selection is random of patients or materials, okay? And then also you must have a control or a comparison with a standard, for example, treatment or a standard method, okay? Or a placebo, for example. And a trial means experiment. So you are making an experiment with no selection bias and with a comparison with another group. And that's bias theory avoided, as we mentioned, by selecting a sample of participants from a particular population and allocating them randomly to the different groups. They are characteristics of RCT, and these are first is randomization, which we just described, and a control, which is in comparison with a standard treatment or a placebo, and then blinding. Blinding means that the patient doesn't know what type of treatment is he receiving. So, for example, you're comparing two different drugs, or having a placebo, which is a drug that does not have the material inside it. Okay, so in this case, patient doesn't know, so there will be no influence from the patient decision, and also from the researcher who's doing it. So it could be a single blinding, like only patients are blinded, or double blinded, where patient and researcher are blinded. So the researcher in this case does not know when he's making the comparison on which treatment, for example, which method is used with a group 1 or group 2 or any particular patient that is under evaluation. And then follow-up. Follow-up is very important. For example, if you are doing a study and you need to have a follow-up with a specific time, for example, if you're looking at tumor and 5 year survival, or you're looking, for example, survival of implants, for example, in orthopedics, then in this case, it's very important to have a long-term follow-up. This can go even up to like 15 years or longer. So the follow-up, if there's a loss of follow-up with large number of patients, because some of them have died, some of them disappeared, some of them did not come back to you, in this case, this can risk the validity or quality also of that research.